So we've got this meeting set up to talk about HPV, human papillomavirus, and the male perspective. Oncologists and head and neck surgeons like myself are seeing an increasing number of patients presenting with oropharyngeal cancers, that is, mainly cancers of the tonsil and base of tongue, when all other mucosal cancer sites are decreasing in their frequency of presentation. Most of the patients we see present with upper aerodigestive tract symptoms like a sore throat, pain radiating to the air, sometimes some blood being spat up, and then also patients present half the time with a lump in the neck, and that's usually in level 2 or the upper part of the neck in the jugular-digastric region. Over the last 20 years, it's become evident that the cause of these oropharyngeal tumours is human papillomavirus, type 16, and it's been shown to colonise the upper aerodigestive tract, particularly in the lymphoid areas such as the base of tongue, where there is a lingual tonsil, and in the pharyngeal tonsil in the what we would normally consider to be the tonsil. This disease is present more frequently in men by a ratio of about 4 to 1. As many of you are aware, the Ministry of Health funds a program to immunise girls against HPV, primarily to prevent cervical cancer. The purpose of tonight's forum is twofold. Firstly, to raise awareness of this disease in males, particularly in terms of the head and neck oropharyngeal cancers, and also to advocate for Ministry of Health funding for boys, to prevent future growth of this disease and the rates that we're seeing, the increase of it now. So we've got a number of experts on our panel, and I'd like to introduce them all individually before they speak. First of all, I'd like to introduce Grant Munro. Grant is a molecular biologist and virologist from Wellington. He currently is the virology team manager for animal health laboratories for the Ministry of Primary Industries, and previously was a senior research fellow for the vaccines group in the Department of Molecular Medicine and Pathology at the University of Auckland. It was bitterly ironic that in September of 2013, Grant was diagnosed with a T2N2B P16 positive HPV-related squamous cell carcinoma of his left tonsil metastatic to his neck. He was subsequently treated with chemoradiotherapy, and he will describe his first-hand experiences of being involved with this disease. Grant.
Bit of deja vu. In a previous lifetime, I've lectured to medical students here when I was working with John Fraser. Right. I wasn't quite sure what to talk about, so I decided I'd just talk about everything. So this is just the brief outline. I've got 10 minutes and 10 slides, some with more information than others. So this is just the basic outline I'm going to give. So as was mentioned, my background is in infection and immunity and working on vaccines for all sorts of infectious organisms all around the world, really. And then ending up in Wellington. So the object lesson here is don't rationalise away symptoms. Following on from my mother, who was a nurse, a nursing sister, who put up with a bit of a sore tummy for a bit over a week and then was admitted as an emergency with an appendix on the point of rupture. I had a bit of a bad hay fever season. Every spring, the pine pollen, particularly down around Wellington, gets to me. There are a lot of pine trees, and the gentle breeze up from Wellington tends to distribute the pollen widely. And the same in autumn. I have problems with fungal spores. It's not really an allergy, it's just physical irritation, particularly with the pollen. But this particular year it went on for longer than I normally experienced. I had a cough, which I always had at that time of year, a bit of a lumpy swallow, which I often seemed to have at that time of the year. I was snoring a lot more, I'd have to say, and just occasionally there'd be a small trace of blood in the sputum, but not much. Just recently I was reminded, with it being hot nights, that I went through a period of ferocious night sweats. Working for the government, MPI, we were in quite a high stress position, the work we do supporting primary industries. So work was stressful, didn't sleep all that well, general life stress. And then there'd been several articles and programs that mentioned menopause, the male equivalent of menopause. And that seemed, it's a rational enough sort of thing, my sort of age, if everything seemed to fit. And then eventually I did what I should have done a long time earlier, which is got a torch out and washed my hands and poked my finger around. That had me very quickly off to see my GP. He had one look and referred me down to an old friend and colleague of his, an ENT consultant, and she saw me very quickly after that. And she's very, very direct, doesn't pull punches, but very informative. And she said, I don't think it's going to be good news. I'm pretty sure it's 95% sure it's squamous cell carcinoma. And the next week, she whipped out the left tonsil, went off for histo. That was confirmed. It was staged, and the immunohistochemistry came back as positive for HPV. And within a matter of weeks, it really was very quickly. I was straight down to Wellington Hospital and being seen by the team there. We decided that it would be 6 weeks radiation and chemo over Christmas and New Year. I had Christmas Day and New Year's Day off, but I had to make it up at the end, so I had an extra half week. There was a hearing baseline because cisplatin, one of the side effects can be an increase in tinnitus, and I was just checked for that. I'm not quite sure what the basis for this was because ACC, there is an increase in my tinnitus and hearing loss. ACC won't cover it because it's a recognised side effect of the therapy. So whether to get hearing aids or not is another question. There was a thorough dental check because your mouth is a major source of infection once you're getting your head and neck treated. And your immune system crashes. And it's a systemic immune system crash as well. It's not just local. So that was all checked out. And the other reason for doing that, with the treatment, you lose your salivary glands. Some of them come back, so a degree of saliva does come back, but the actual components of saliva from the different glands are different. So what I have now is saliva that has very little calcium in it, which is required for continual replacement of calcium leaching from teeth. It does mean that I don't have any build-up of gunk between my teeth. But it does mean that during treatment and going on later, you have to keep taking high fluoride mouthwash and toothpaste and using those and be really rigorous about dental hygiene. There's general health checks just to make sure I was going to survive the whole thing. The mask fitting, this is a big mesh mask that they mould to your face and your shoulders and pin you down to the table when you get irradiated. And you get a very dainty little tattoo to localize everything. The treatment was all pretty routine, apart from chemo days when your whole body swells up a bit and that was the one time when I was pinned down in the mask and I couldn't breathe. It was like having a pillow over your head. So there's lots of this going on, and they pinged me off very quickly. So after that, little spaces went in on those days. I'd have to say that looking around the treatment room, I was 90% better than the vast majority of people in there from the point of view of side effects and how quickly side effects appeared. There were some people who responded very badly to it from really quite early on. I didn't until right towards the end, and then it got really pretty grim. So the side effects that develop, as I said, I was probably in the top 90% or plus for not avoiding them, but not being too bad. It's interesting that your taste buds, different taste buds and sensations must have different replacement rates. So rather than losing your sense of taste all at once, you lose certain components of taste along the way until you do actually lose everything. And the same when it comes back. You develop them in different phases coming back. The dry mouth, that was, and still is, I still have to walk around with one of these. It was particularly bad. It's particularly bad at night. You have to learn to sleep with your mouth shut and breathe through your nose. It is very unpleasant. Skin care, where the radiation goes through, that's fairly obvious. Really bad sunburn. Hair loss was amusing in a way. It was like a really bad bowl cut right up at the back here, but I couldn't see it, so I didn't care. Loss of energy, that was interesting, given the localized radiation and treatment, just how that wipes out all of your energy a lot of the time. It also gives disrupted sleep patterns, and memory is processed while you're sleeping, and with a disrupted sleep, I found and still find that my memory isn't as good as it used to be, and particularly during treatment, there are swathes of time which I don't remember. In particular, my team has a budget of $1.2 million. I did the budget during that period. I have no memory of doing that budget. I got it right to within 1% for the year, but it's quite bizarre. Sitting in a room and they start talking about the budgets and how people are tracking, and I'm sitting there thinking someone must have done it for me. I can't remember doing it. So after 6 weeks, as I said, it gets really grim. It gets to the point where you can't swallow anything, not even water, without lignocaine syrup, and you have to take a big mouthful of the syrup and wash it around. Numb your whole mouth, gently let it trickle down your throat to numb your throat, and then you can drink water or the high-protein energy drinks, which is all I could take at that time. So I went, before treatment, I'd managed to bulk myself up to, I think, 94 kilos or something, and I think I went down to something like 76, and I'm back at 83. Once treatment stops, it was almost as though things got worse after it had stopped, before things started getting better, and I went through a period where I was sleeping or dozing 20 hours a day, and just no energy at all. Fortunately, MPI has a special, not holiday policy, but a special allowance policy for leave, and I was allowed to take the leave that I needed. Temperature control, with the massive loss of weight, even though it all finished in summer, I was cold all of the time. Did allow me to invest in my wide range of icebreakers, which is great, but I still suffer from cold, and whether that's another of the side effects from the cisplatin, where you can get numbness. I don't have numbness in my fingers, I do have numbness in my toes, so I'm slightly wobbly at times. I was really lucky. I only had one infected gum event when a bit of a temperature, and that had me in hospital for 4 days on IV antibiotics. Recovery is really surprisingly slow, very slow, very poor energy. Part of that might be difficulty eating and swallowing. It takes a long time to get back to eating properly, even though you're really focusing on eating the high-calorie stuff and things which are easy to swallow. A lot of foods you can't swallow easily, even once they're well chewed up. They can become like a papier-mâché, and particularly pork and chicken was like that. Surprisingly difficult to swallow. So you end up drinking a lot of water with every meal. As well as a poor appetite over the 6 weeks, because you haven't been eating much, your stomach, I think, shrinks, you don't have the capacity. But because you're sipping water all of the time, you also fill up very quickly. So I used to have try to have my usual old size plate of food, and I could only eat a half or a third of it. And I think part of that is that you are washing stuff down with water all the time, and you just fill yourself up. Taste does eventually return to what I call the new normal. I seem to need a lot more salt than I used to make things taste right, and I think there may be some effect from the high sodium fluoride in mouthwash and toothpaste that I use. And there's a dental mousse and all sorts of stuff that I use. And whether that's tricking the sodium receptors in the mouth, I don't know, but certainly I am using more salt. And saliva flow does return, but it's really only about half what it should be, and the components are completely different. So because of that, after treatment you have dental checkups to make sure things are still good there. As part of losing calcium on your teeth, fillings and little bits around your gum, which they've filled in because of erosion, they've actually been held in by the calcium and that isn't part of the tooth, but it's I've forgotten the name for it now because I don't have it anymore. But I had fillings simply fall out, and teeth which had slight cracks in them, the side of a tooth would simply fall off because of this decalcification that happens. So it is really important to use those, the dental mousse. As I said, the audiology check, I do have increased tinnitus. The only other side effect is second and third toes on each foot seem to be numb continuously, and it's surprising how much you need them to not wobble if you're going down steps and things. And I was having regular clinic checkups, started out monthly, 2 monthly, 3 monthly, and I've got out to 4 monthly, and it's all pretty good. And then I mentioned a couple of weeks ago that I had a bit of a stiff neck, and again, rationalising it's the side and the exact area that got the highest doses of radiation. So it's probably just explain it away as scar tissue. But David Hamilton sent me off for a PET CT scan, and there's a lymph node in there which is not looking as it should. So there's probably some more investigations to go and some more work to happen. But these things happen. You inform yourself, you knuckle down, you do what you need to do, and you try to advise others, which is why I'm very grateful to the HPV project for putting this on, and the whole initiative behind lobbying the government to fund the vaccine for boys. I've got a boy who's going to be 15 tomorrow. I paid for him to be vaccinated. It would be hypocritical of me not to, given my science background. But having been what I've been through, if there's any possibility of preventing it in him, it's certainly worth relatively modest, $450 or so that was there. So the other acknowledgements, my GP Marcus, Kathy Ferguson, who's the ENT consultant I saw, David Hamilton, the head and neck oncology team in Wellington, all the others. The Cancer Society in Wellington, they provide free parking for people while they're having treatment, which is an absolute godsend. And of course, family and friends. I think that's me. Thanks.
Thank you very much, Grant. Look, I know that you said earlier that you felt obliged to come and talk here, but I think it's incredibly brave of you to come and share your experiences and just really show the grim reality of treatment and the effects of this disease. We're going to take questions once all the speakers are done, rather than having them in between talks. And now I'd like to introduce Julian White. Julian is an otolaryngologist and a head and neck surgeon at Waikato Hospital. He trained in Otago, completed his otolaryngology head and neck surgery training in New Zealand, and then did 2 postgraduate fellowships in Canada, the first at Princess Margaret in Toronto and the second at Western University in London, Ontario. Julian's been a consultant surgeon in Waikato since 2008, and he has a special interest in HPV-related oropharyngeal cancer and salivary gland disease. He's a good friend, and I'm looking forward to his speech on the epidemiology of HPV-related oropharyngeal cancer and primary and secondary prevention. Julian.
Okay, thanks very much, John, for that, and thanks, Grant, for sharing your story, which, as we are learning, is an increasingly common story. As John's already mentioned, well, that's not going to work. As John's already mentioned, no, first of all, I just feel I do need to make a disclosure. So last year I did receive an education grant from BioCSL, which is now Sequoias, which helped me to go to the International Papillomavirus in Lisbon, which is not something that I'd planned on going to, and I was very happy to be asked, and very happy I went. I learned a lot from that. When we talk about the oropharynx, what we mean is that part of the swallowing part of the throat between the hard palate and the hyoid bone and epiglottis, and as far forward as the anterior tonsillar pillar. And the 2 areas that are most likely to be affected with cancer are the palatine tonsil, which, as John said, we call the tonsil, and also the lingual tonsillar tissue, which is similar tissue on the back of the tongue, and we usually call that the base of the tongue, or posterior third of the tongue. Again, as John said, most other cancers in the mucosal surfaces of the head and neck are decreasing in incidence, but oropharyngeal cancers are increasing. And this is quite a widely used slide, which illustrates the rate of oropharyngeal cancer in comparison to cervical cancer, which is really a similar process. And so cervical cancer, this is American data from actually 4 states in the United States, which show, that was premature, anyway, it'll stay there. So it shows that cervical cancer is falling, oropharyngeal cancer is increasing, and particularly in men, which is this line here. And in 2010, in this part of the United States, oropharyngeal cancer in men became more common than cervical cancer is in women. So this here is similar data from New Zealand. So we see a similar sort of pattern, but not quite the same. So in the last, since 1992, there has been a significant decrease in cervical cancer, which is essentially a result of the cancer screening program. But in New Zealand, it's actually plateaued over the last 10 years or so. Oropharyngeal cancer has increased similar to that seen in other places, including the US, and again, particularly in men. And it seems to be continuing to increase. The lines haven't crossed as they have here, but I'm not sure exactly when they will, but they're certainly a lot closer than they were 20 years ago.
This is a slide I prepared for a talk I gave 2 or 3 years ago when I only had international data to go on, and at that time it was said to be up to 72%
were HPV positive, and so the rate of HPV positive cancers in the oropharynx have been increasing, whereas HPV negative cancers have been decreasing in line with the other mucosal head and neck cancers. We've actually got local data now. So in the Waikato, we looked at our own series for over a 5-year period and found that 89% were P16 positive. So P16 is a surrogate marker for HPV, which isn't a perfect correlation, but it's pretty good, and it's cheaper and easier to do, and it's a commonly used surrogate. So we think about 90% of our cancers are related to HPV, and I understand that there's a similar rate in Auckland and presumably other places around New Zealand. So oral HPV infection is actually very common indeed, and so 80% of sexually active adults will have an HPV infection at some stage in their life, and most of those infections will be cleared within a year or two, but in a minority of people the infection persists and can lead to precancerous and then ultimately invasive cancerous lesions many years later or even several decades later. In the oropharynx, the HPV types, so there are over 100 types of HPV which are numbered, and the HPV types in the oropharynx are similar to the ones seen in cervical cancer and predominantly HPV 16. The pattern is actually slightly different between those two sites. Only about 70% of cervical cancer is HPV 16, but it's a very similar thing, and it's not, we don't believe that's an accident. The mode of transmission is thought to be oral sex as the primary modality. There are other possible ways of transmitting the virus, possibly. So it's most likely to occur in males and younger age, so various sexual activities are related to the probability of developing oropharyngeal cancer related to HPV, and it really, in particular, is younger age at onset of sexual activity and increased number of sexual partners, and particularly oral sexual partners. And it's a proportional relationship, so the higher the number of partners, the higher the risk. So why is the incidence increasing? Are there really, is there really a change in sexual practices? Surely people have been practicing oral sex forever. Well, actually, there have been changes in sexual practices. This is from a survey in the United States. We basically surveyed the various generations and the rate at which they participated in various sexual activities and at what age. And generally speaking, the younger generations do have a younger age at first sexual contact and do have higher numbers of lifetime sexual partners and more likely to have performed oral sex. And that's true in men and in women. This is another one which I debated whether to put in, but I think this is a minor effect. So we actually, there are more tonsils as well, and that probably does have a small effect on the rate of oropharyngeal cancer. You can see that, well, the heyday of tonsillectomy was in the 20s, 30s, 40s, and then once antibiotics started to be used, it decreased, and in this 20-year period it fell by more than 75%. This is American data, and I haven't been able to find New Zealand data, but I suspect that it would be something similar here. And there have been some studies which have suggested that this does play a small part in the changing incidence, but it's lesser than, or thought to be lesser than, the changing sexual practices. So why does it affect men more than women? And so there are several thoughts about that. One is that, and this it's known that women mount a stronger immunological response to infection with HPV, and so can clear any infection more readily. There is a higher rate of genital HPV infections in women, and in those women who have genital infections, there is a greater viral load than there would be in a man with a genital HPV infection. And so for a heterosexual male, there's greater exposure to the virus through oral sex. And there's this small effect from the fact that males generally practice slightly riskier behaviour than females in terms of younger age at first sexual contact and number of partners. So there are several reasons there why it should affect men more than women. I would just state too that it's not only oropharyngeal cancer, and this comes into the equation when we think about whether or what to do about preventing cancer. And so again, this is US data, but there are other anogenital sites which can affect men as well. And overall, in America anyway, about a third of all HPV-related cancer affects men. And HPV does cause other non-cancerous conditions, in particular anogenital warts, and in the upper airway, recurrent respiratory papillomatosis. So they can all affect males as well. So the next part of my talk, I just wanted to talk about what we can do to prevent HPV-related oropharyngeal cancer. And there isn't just one way, but there is one way that's better than all the others. But I'm going to mention all of these. So primary prevention means preventing the infection or the development of precancerous or cancerous lesions in the first place. Secondary prevention is essentially screening to try and pick up cancer at an earlier stage. I'll just mention a little bit about secondary prevention first. Cervical cancer has decreased in incidence largely because of screening, and so the thought is, can we do something similar in the oropharynx? The short answer is that so far something like a pap smear hasn't been very helpful in the oropharynx, and the reason for that is largely to do with the inaccessibility of the sites where the cancers first develop. So in the palatine tonsil, there are deep crypts which are lined with specialised epithelium which concentrate microbial particles such as viruses and expose them to the lymphoid tissue. And that's where most of these cancers start off, is deep in the crypts of the tonsil, so that brushing the surface most of the time won't sample those areas. And then the tongue base, that's simply less accessible than parts of the tongue that are further forward into the oral cavity. So cytological methods of screening have not proven to be very helpful. It is possible to do blood testing, so serological testing for antibodies against proteins that are produced by the virus, and those sort of tests are in the early stages of development. It may be that one day there will be a blood test which can at least detect people who might be at risk of developing cancer, but there's a lot that needs to happen for that to become a useful screening test. So at this stage there isn't any validated screening test for oropharyngeal cancer. In terms of primary prevention, I will mention three things. The first is tonsillectomy, and it's almost as a throwaway thing, but it's not quite as ridiculous as it might sound. In 2008, the paediatricians and the ENT surgeons in Australia combined to produce this report, which is on indications for tonsillectomy and in children. And one of the main findings was that they didn't feel that we were doing anywhere near enough tonsillectomies. In fact, that we should be doing 7 to 10 times as many as we are to treat sleep-disordered breathing in children. And I know that that changed my own practice and changed my threshold for recommending tonsillectomy in children. Of course, this isn't a realistic way to go about preventing oropharyngeal cancer, simply because it's a morbid procedure, and even there is a risk of mortality, and purely there aren't the resources to consider doing it. So maybe won't say much more about that. Can we change behaviour? The main risk factor for it is various sexual behaviours. So what we do know is people have looked at whether behavioural change can affect the incidence of other sexually transmitted infections. And I'm not a sexual health physician at all, but what I've found is that there is some evidence that education can improve knowledge about how these diseases are transmitted. And there is some evidence that some behaviours can change, perhaps condom use, for example, and some studies have suggested that it might reduce the number of sexual partners. But really, this is not going to make any significant impact, considering that although increasing numbers of sexual partners, for example, increases risk of oropharyngeal cancer, even exposure to one person with HPV, can provide some risk. So behavioural change on a population level isn't likely to make much impact. Which brings us to vaccination. So most of you will know that there are 3 HPV vaccines that are commercially available. All of them are active against type 16 and 18, which are the 2 types that are most implicated in cervical cancer and also in oropharyngeal cancer. Cervarix is a bivalent one, which only is active against those 2, and that's not used in New Zealand. The one that is in general use and as part of the vaccination program in New Zealand is a quadrivalent vaccine called Gardasil, which is active against not only type 16 and 18, but also type 6 and 11, which are the types that cause anogenital warts and also the recurrent respiratory papillomatosis that we see in the upper airway. That's been approved in New Zealand and is free for females up to age 20. Uptake of the vaccine is not all that great. Only about 55% of women who are eligible for the vaccine have had 3 doses, which is what's currently recommended. It's approved for use in males, but as Grant mentioned, is currently not funded, and so patients would need to pay, or individuals would need to pay themselves, and it's about $450 for a 3-dose course. Recent development is the 9-valent vaccine, which is also Gardasil 9, which in addition to those 4 types from Gardasil 4, has activity against 5 other oncogenic types of HPV. And that's recently been registered in New Zealand, and I'm told is likely to be available from sometime in 2017. And there have been submissions made to get the 9-valent vaccine made the standard one for the vaccination program, and it covers more, particularly of the types that cause cervical cancer. So does HPV vaccination work? Well, it's too soon really. It hasn't been in use long enough to show that it prevents cancer per se, or invasive cancer anyway. What we can say is that it prevents benign disease due to the virus or types of virus that are covered by the vaccine. So this is national data on the number of individuals with genital warts presenting to sexual health clinics. So this is from 2005 to 2009, so it was fairly static. The vaccine was introduced in 2008, maybe a slight drop there, and since 2009 there's been a steady decrease and quite significant decrease in the number of genital warts present, and that's been demonstrated internationally. So this is a large systematic review and meta-analysis. Just briefly, because it's quite dramatic really, these are females, and these ones are in areas where there's high vaccine uptake, over 50%, and these are different ages of women. So in young women, genital warts have almost been eliminated in areas where there's high vaccine uptake, and it's a bit less in the older women, and a less effect if the uptake is less than 50%. These are the males in the same population. So where there's high uptake among females, the males aren't being vaccinated, but they are seeing a reduction in genital warts. So this is the herd effect, which is lost when uptake is less than 50%. So certainly HPV vaccination is very effective in preventing genital warts. It's also been found already to be effective in preventing high-grade abnormalities in the cervix. This is a case-control study from Australia, where they found a risk reduction of 46% from having 3 doses of the vaccine. That's for high-grade abnormalities. So yes, HPV vaccination is effective in treating benign and pre-malignant conditions, and there's every reason to expect that it will be effective also in preventing malignancy given enough time. Is it safe? So there's a lot of data out there about safety. If you want some numbers, this is from the Gardasil 9 sort of pre-marketing assessment. Gardasil 9 has more local site adverse effects than the Gardasil 4 to do with increased immunogenicity. But local injection site side effects are very common, indeed particularly pain, as you might expect, and also these others, swelling, erythema and itchiness. A small number are considered severe. Also some systemic side effects which are fairly non-specific. In terms of serious events, so in that pre-marketing study there were over 15,000 subjects, and there were these 7 so-called serious events. But when you look at what they were, there was one allergy to the vaccine which was considered to be a definite reaction to the vaccine, and it is possible there was a very small rate of anaphylaxis to all vaccines, and including Gardasil. Someone got asthma 2 days later, an asthma attack. These other ones, tonsillitis, headache, pyrexia. There's postural orthostatic tachycardia syndrome, which is something I'll mention briefly again later, but some years after vaccination. So the link with the vaccine is very tenuous at best. In fact, you'd need to say non-existent, or you'd be inclined to say non-existent. So there were no deaths related to the vaccine either in this testing or confirmed deaths related to the vaccine after marketing. So safety is a big issue when you look at the media, and so conventional media and also social media, and there are some reports in both of those areas where people are convinced or feel strongly that that the vaccine can cause very serious and actually quite harrowing effects, and there are videos on YouTube and have been on television and on Facebook and in many places. And in fact, in some places around the world, those sort of suspicions of adverse effects from vaccination have had a very detrimental effect to the vaccination programs. For example, in Japan, the uptake has gone from in the 70% to almost zero through coverage of supposed reactions. And there are many authorities around the world, regulatory bodies that have made statements about this. All of them have said that there's no evidence that vaccination causes any of these serious problems. And perhaps what I feel might be the most significant one is this World Health Organization committee, who's worked over 6 years looking at this and specifically considered a number of these things which have specifically been thought to possibly be related to HPV vaccination, and have found that really there's no evidence that this is the case, and that they affirm the benefit-risk profile remains favourable. But they actually went a little bit further than that, and recognising that that these can have quite damaging effects on people's confidence in the vaccine and in vaccination programs. And they actually made this comment that, first of all, adverse events should continue to be reported, or suspected adverse events should be reported and should be looked into. but that allegations of harm from vaccine based on weak evidence can lead to real harm when, as a result, safe and effective vaccines cease to be used. So this is something that I think is important for media and anyone who is suggesting that HPV vaccination should be in some way discontinued or decreased should consider. I will briefly mention, I think I'm probably running out of time, but vaccination of boys, so vaccination in general is likely to be very effective and, as far as we know, is safe. Vaccination of boys is actually increasingly being approved in different jurisdictions. In various places, including in New Zealand, there has been some question mark around the cost effectiveness. When we ask governments to fund a treatment or, in this case, a vaccine, the governments are very interested in costs and cost effectiveness. So there have been some, this is a large cost effectiveness study from Canada, who felt that adding the vaccination to boys was not cost effective if the coverage of girls was over 50% because of the herd effect, largely because of that. But that it would be cost effective if coverage of girls was low, below 50%. Remember, in New Zealand it's about 55%. But they do say also that if coverage of girls is low, that it's actually more cost effective to increase female vaccination. So that's what they say, and there's a similar study from New Zealand which has concluded similar things, so best value for money by improving vaccination coverage for girls, although they do say that if the vaccine costs, the actual cost of the vaccine and administration of the vaccine become very low, then vaccination of boys may become cost effective. So the government will look at this sort of cost effectiveness analysis, but there are some concerns about those, and when you look at them it's actually quite interesting. So those cost effectiveness analyses actually underestimate the number of oropharyngeal cancers that are attributable to HPV. For example, in the New Zealand study, they quoted it as 20%. Now, they were a little bit confused. They actually included oral cavity ones, but they called them all oropharynx. But either way, it's 90% in Waikato anyway. So that's one thing. They don't account for increasing rates of oropharyngeal cancer. I'm advised that I think the actual cost of the vaccine to the government is a bit of a secret, but I'm advised by reliable sources that they've overestimated the cost of the vaccine to the government, that the cost of the vaccine is likely to be less per dose if both genders are vaccinated. And there is talk about a 2-dose schedule, which may well be as effective as a 3-dose schedule. Costs would further decrease. And there may be a possibility to decrease administration costs by giving it with another vaccine, a DTP vaccine, in year 7. And also, they don't really, most of the girls who want to be vaccinated or whose family want them vaccinated already are being, so there would be a cost involved in getting more girls to be vaccinated. So as much as anything, though, I think it's about equity. So boys shouldn't have to rely on the herd effect from girls being vaccinated to obtain immunity from the disease themselves. And this is particularly true for men who have sex with men. The Human Rights Act actually prohibits discrimination on the basis of sex, and this, in effect, is discrimination. And really, it could be regarded as one single herd. And so vaccination of boys would benefit females as well. And it can be cost effective, especially if the vaccine costs and vaccine delivery costs are kept down, and as well as lobbying the government, which the New Zealand ENT Society is in the process of doing. We should also keep some pressure on the vaccine companies to keep their costs down. So HPV is more than just cervical cancer. HPV-driven oropharyngeal cancer is increasing, especially in men. HPV is a very common infection, and vaccination at this stage is by far the most appropriate way of preventing HPV-associated oropharyngeal cancer and other conditions, and we would support an increase in vaccination and vaccination for boys.